Taylor, and thank you to the Scale family for having us. It's an incredible privilege, and I'm excited here to have Erin Meary and Cletus Earle joining us. So as background, I'm with ScaleHealth in their biodesign program, where we focus on new technology development. And I'm pleased to be here with Erin Meary, who's the CIO of UT Health Austin, and also Cletus Earle, who is the CIO of Penn State Health. And I look forward to continuing the conversation with them as we discuss the silver linings with COVID. So to kick us off, Erin was, both Erin and Cletus are also have been in healthcare for quite some time, and have also Erin previously served as CIO of Imprivata and also of Walnut Hill Medical Center and CTO of Children's Health System in Texas. And then Cletus also previously served as Kaleida Health's CIO and St. Luke Cornwall Hospital CIO. And given the depth of your experience previously, Erin and Cletus, I was thinking that we could kick off the audience with sharing the differences between a community health and community hospital group compared to an academic and a larger health system that you both are now managing. And maybe we'll kick it off to Erin first and then go to Cletus.
Yeah, I'll keep these comments brief. So first of all, thank you for having me. Appreciate being here. So in the context of it, academic medicine is a multidisciplinary, multi-tiered organization. And what it means for you as a CIO or as a decision maker is that you have numerous leaders you've got to work with, get in consensus and work together on. In addition to that, you also have this fun thing called research, which every day is a different day when it comes to research. And then of course, in our case, we have a medical school as well. So all three pillars work together to deliver the top product, which is a high quality patient outcome. And in our case, top-notch research and medical students that are graduating to become doctors, particularly in this day and age of COVID-19 and getting it to goal. So to the degree of it, there's not too much else different though when it comes to community health centers. We're all focused on the same thing, which is high patient outcomes, quality outcomes. But yeah, academic medicine has multi-layers. Cletus?
No, first of all, I agree, Erin. Thank you. And I see you have your horns up there. I have my shirt going on underneath. So, we're representing our facilities, the
Right.
lion and the longhorns there. So thank you for being here and thank you for inviting us. Very, very pleased to be here. I like to add one other element, that our organization, as Erin pointed out, academic medical center, our organization actually, our health system originally was created for the College of Medicine many years ago. So it is inherently tied together. As a matter of fact, on our megastructure, you can't tell the difference where the academic ends and the health system begins, as we have multiple hospitals as well as other types of facilities on the megastructure. But over the course of the years, what we've chosen to do is develop and become a health system, and that's where Penn State Health was created. And we started to bring in the traditional hub and spoke, where the academic facility is the tertiary quaternary care, so the advanced care, and then tying in to community hospitals where care is local, and any of the advanced types of procedures need to be pushed back to the academic institution. So we are truly a fledgling health system, because we've started this journey a few years ago, but we're in the central Pennsylvania, and we go from city to rural very fast. So we are a dichotomy of different aspects of what you would see in your traditional health systems. In my organization, as far as having oversight of the College of Medicine, I also have the oversight of the health sciences. So we are one of the first humanities schools for the College of Medicine. So there's another dynamic on top of the R1, which is a Research One institution, as you can imagine. When you're R1 and you're competing for the dollars, such as Erin and his team, it's a very dynamic, let's just say, environment, because everybody needs what they need, and if the funding comes in, they need to get it done immediately. So you have that academic/research piece that is a whole different element from our organization, how we operate.
And help us understand maybe the size of each of your organizations, just because I think the enormity of it is quite large, and I don't know that people understand it until they truly hear it.
Cletus, you want to start?
So at the university level, we're pretty big. We're a pretty big university. We have about 104,000 students. At the college side, it's, you know, and again, you can't tell where one ends and the other begins. You know, we're throughout the entire state, the Commonwealth. The college side, we have just traditional, you know, 2,000 to 3,000 or so people. I basically have oversight of about 28,000 people. You know, not as big as some other organizations, but you could imagine it's not an easy task. I do have a medium-sized organization. I'm sorry, I'll back up. The university, about $7 billion. The health system, about 3.5 billion. So it's a multimodal dynamic, and you know, I have a relatively mid to large team, you know, of about 600 people that spans across the college and the health system.
Yeah, and UT Austin actually looks very similar to the way Penn State works. It's actually funny. I know a lot of our structure and stuff were actually derived from a lot of the learnings there and some of the trials and tribulations they went through. And we have a lot of leaders actually came from there. So it's interesting as I look across UT Austin and the similarities there. R1 as well, about $6.5–7 billion annually. You know, and then from a health system side, of course, we've got the medical school, and you've got the clinics, and you've got the hospitals, multi-hospital, adult and pediatric, and then research all throughout, right? So you really can't tell the difference of where it goes from an MS1 student all the way to MS4 to residency to actual practice, clinical care, and then to research. It all happens like in just buildings you kind of walk across the whole campus to. All anchored, for those of you who know Austin, all anchored off the I-35 corridor, right just south of where the Longhorns play. And so it's the entire medical district of Austin is basically my purview. There is an undergraduate IT team that operates for UT Austin for a lot of like the dormitories and stuff that just are not my purview as the health CIO. But we work together with them as things span across, especially for some of our MS1 students that do stay in the dorms, which is something they can do. They can rent out an apartment there, but that's really as far as it goes. My entire span of control is the whole health side. And I too also have a pretty robust team, a lot of data analysts and engineers, and a lot of DevOps folks.
Yeah, and just to it's very funny because president of our mega structure comes from UT. So yeah, there's a lot of back and forth for the academic sites, whether it's UT or Duke or others. You know, there's a lot of back and forth with the resources.
And both of you have been CIOs for quite some time. Tell us how did COVID? People have heard COVID upended, you know, a lot of business as usual. How were you planning things previously, and how did COVID shift that a little bit for you?
Yeah.
So I would say a couple of things. Number one, there's a misnomer out there that COVID suddenly dried up the IT funding and CIOs had to pull back. That's actually not true. We reallocated funds towards exactly what we needed to. So I would say it opened the eyes of the business leaders on the value of being agile and really double downing on SaaS-based and cloud-based technology stacks. In addition to that, we were able to get through some of the healthcare by nature of it is a very compliance and legal driven function, to where open source and others before were very taboo. When you're trying to go fast and every minute counts and saving lives, you're able to get through some of that bureaucracy, I'm going to call it, and really open your eyes to the value of tech. Now it's about streamlining efficiency, ease of access, availability, and making sure that good customer service is there. Because remember, we're still in a hybrid model. We're probably never going to go back to all in person, but you got to be able to serve both constituents effectively. Last but not least, I think organizations really looked at who they were partnering with, who are the BAAs and others that we are working with and spending a lot of money with, and are they invested in our organization? If you were there in the trenches with me the day we launched our vaccine hub, one of the first 4 in the state of Texas to do that, if you were there in the trenches with us when we were on Super Bowl Sunday, standing at the Gregory Gymnasium to house 5,000 people a day coming through, if you were there on the beginnings of all this, we were doing our drive-through testing and standing at the initial CLIA certified labs. Those are the vendors I'm working with today. If you weren't, if you were unresponsive, believe me, when FY22 kicks in here in another month, you're no longer a vendor of ours. I don't care what it takes, because to the degree of it, UT Austin is not going to tolerate that anymore. You don't just get paid to be paid. So make sure you do not forget about customer service.
That is said very well. I can tell you one thing COVID has done, it is redefined how we are going to move forward. I'll just go back a bit, and I can tell you many organizations unfortunately have been impacted in people. We know that Me being a New Yorker, I could tell you, I've known many people that died on the first wave in New York City. And it's a game changer, not only the fact that we're also not going to be a fully, at the in-person facility. We've decided to be 50%, but our organization, as we continue to grow, we had to understand, hey, how do we continue to, grow at the rate we were? Well, our board asked us and challenged our CEO with a simple question. And he asked has things changed as far as the landscape of our business and what's going on around the region? And the answer was no, nothing changed. So therefore, our board gave us a directive, then you continue. We are building our hospitals. We're still building hospitals. We have one opening in, a month and a half. We have another hospital opening next year. So net new, we're still bringing in practices. So we have not changed anything. Now, not all organizations can say the same. Totally understand and respect it. We just happen to be in this particular position. But what it has done, very similar to Aaron, the excuses are gone and technology has been the bridge. We now realize that we can operate at this pace, which can be a problem because you have to worry that you don't, tax everybody and put everything on our staff's shoulders. But we know we can operate. If we can operate and do all the things that we have done in a mobile environment and with all this agita, then I know we know we can do other things and perform much better. So it's a tipping point, in my opinion. And I believe that we're on the other side where the healthcare industry has been very slow compared to other industries and verticals. Now with COVID and what we have been able to show is that we can operate, we can be agile. Like what Aaron said, there is no longer the ability that we buy things and you don't utilize them. You have to be very efficient. And I think this has created muscle memory. Those who play golf, know how that works. It's created this level of muscle memory within the organizations that you either perform and you provide the most efficient process or you're going to fail. And we have decided that we are not going to fail. And I think that is a cultural dynamic that has really shifted with COVID, the onset of COVID. And now, unfortunately, it looks like deja vu, the Delta variant that's coming down the pike.
Absolutely. And how did each of you tap into the innovation ecosystem prior to COVID and or during COVID? I know, Aaron, previously you've mentioned leveraging, I think, 3D printing, potentially certain elements and materials. And then I know at UCLA Health, we did some 3D printing of some nasal swabs, and that definitely helped with supply shortages. And being tied to the academic ecosystem helped us with that. And I know, Cletus, we've talked before, you've been an advisor to, or on the board, I think, of an accelerator. Can you talk a little bit more about how each of you have, how do you source innovation? Is it from your academic side? Is it from the academic side and startups and bigger companies? Or how do you think about sourcing new innovation?
So for me, it's D, all the above, right? So I'm a big fan of the startup community. I turned to the startup community for a number of things we were doing, especially in the early days. We're trying to figure out, how do we do temperature monitoring and automate that? How do we do these things? I think health systems have a tendency to rely on their big vendors, AKA the EMR vendors and others, way too heavily. So you as a CIO have to be dynamic and seek out everything. The academic side, as much as there's great talent there in commercialization, you can't always rely on that either. There may be great ideas and great researchers, but a lot of times it's theoretical research versus actual practical, put it in practice, make it happen. So that's where the startup community can come in and anchor in. And the point of the 3D printing, we were down to less than 20 days of PPE. And I sat there and said, listen, if I let folks go into rooms with a bandage over their face or a handkerchief, and I could do something about it and I didn't try, I wouldn't be able to live with myself as a CIO. So we turned to 3D printing, we turned to that, and we did it with facial scanning. We built our own, right? N95 that could filter to 0.2 microns necessary. And we outfitted all of our physicians and clinicians with that to get us through the bridge of the divide. Luckily, we got PPE'd about 30, 45 days later. But for that month, that's what held them over. Otherwise, they were literally going to go in there with like t-shirts over their face as the best thing they could get because we were totally out. So to me, that's the hallmark of a CIO, right? That takes everybody from startups to traditional commercialization. I turned to industrial commercial printers because I needed to make sure this stuff could be autoclaved. This wasn't something small. It had to be something that autoclaved and totally reusable, just changing the 3M filter in it. So, I mean, a lot of that was just ingenuity. And when your back's pressed against a wall, do you throw a Hail Mary or do you not? Right. I mean, that's the question you got to answer yourself. What I need is people willing to throw the Hail Mary with me, knowing you may fail, but that's fine. Fail fast and let's keep going and figure out something else.
Yeah, I also say D, all the above. We are innovation in my mind is collaboration to all levels, whether it's the startups, whether it's the the big tier one vendors. I look towards I look towards Silicon Valley, in COVID's time. And also I look towards the 10th grader that may understand how to do something that's in our region. And they could actually be innovative as well, right? Nothing more than having a fresh set of eyes that can tell you, hey, is there a better way of doing it? So I look at innovation in as a multi-pronged approach of, and it's not always creating or building that widget, but also, trying to connect the dots in different ways. I'll give an example. COVID was tough. It was tough for a CIO. And I can give you the reason why. It was so chaotic as far as we didn't really have the leadership to tell us what to do, as a regulated area industry. So in many cases, it came down to the state level that the states would, tell you to do things. Many times we got direction from the state 2 days in advance, a day in advance. And unfortunately, the EMRs are not designed. I can tell you, academic is not designed that way to move that fast. But the EMRs, those vendors are not designed to move at that speed. And we decided to move and partner with a third-party company. In that case, I'll name drop, it was Salesforce, to say, hey, we need to do innovation in a different way. And we, by as an example, we partnered with them and we were able to build a solution within 2.5 weeks. 3 weeks, we had the finished product from ground up. That's failing fast. That's succeeding even faster. And what we ended up doing is the state still made some changes, and there were other things. And we came to find out that, hey, we did not have an electronic way of getting those vaccines to the state because the state decided that they would only accept it electronically. Okay, right? How are we going to do this so we can still hit the initiative? And we decided to then work with our regional health information organization, our RIO, to get them to be a clearinghouse of data, right, for the state and have that integration at the RIO level. Never been done before, right? But working with partners, whether it's local, whether it's regional, whether it's international, that and also with Akamai, which is a major component to the internet to help us remain secure. I mean, we really, you have to start to think differently in order to get those results. And we brought in partners as well as, local partners to make that happen. And that's the way you have to think to be able to deliver.
This dovetails into the next topic I wanted to shift to really well, which is interacting with government agencies and interacting in public policy and also health equity. And Aaron, you're on the Health IT Advisory Committee at the federal level and also on CHIME's policy committee, I believe. And then Cletus, you were chairing CHIME, and I remember email exchanges with us about some, lobbying for some reimbursement, and of course, reimbursement for telemedicine. So some of these CPT codes, helped out quite a bit with finances, I think, with health systems. Can you talk about, what are some of the challenges that were unearthed with health equity, and also how you collaborate in the public policy and public arena in these partnerships to solve some of these challenges? And I know that's a big question, so feel free to take it where you like.
Yes, I'll take it in a couple pieces here. So number one, I feel it's incumbent upon a CIO to be able to voice and articulate in plain English to the various federal and state legislators what is going on. What are the boots in the ground in plain English, not in tech speak, in plain English? What are the challenges? So that's the reason why I co-chair the high tech. I'm not only on it, I'm co-chairing that. I've been appointed twice by Congress. Previously, I was part of the policy committee appointed by Secretary Sylvia Burwell. And yes, I do serve with the CHIME Public Policy Committee as well. And so the reason why I do that is simply to make the world a better place for my two daughters. I realize that this moves at a snail's pace. I realize legislation will take forever, but we're making progress, as evidenced by the latest US CDI version 2, which was just released last week by the ONC. that begins to put social determinants of health and other equity components into what needs to be as mandatory and required fields in all of our data collection systems, aka EMRs and others. The problem we saw boots on the ground was a lot of our structured data and the discrete data, the fields were very, very limited. I mean, you no longer have male, female, you have binary, you have no conformity choices, you have other things that you have to allow for. And when you exclude segments of the population, you actually build fear and distrust, and people don't want to present themselves. So what did we learn looking at that was a lot of missing data elements, a lot of linkages that were just not there, not aware. They will be in the future, hopefully. And then two, this issue of a lack of a unique patient identifier, which Chime and AHA and AHIMA and others have called attention to for probably a decade now, truly bit us in the rear end. It is very hard when we're doing testing and folks go to CVS or Walgreens, then come over for us to retrieve records if there's not a master patient index there. So looking at all these things, this is where Cletus alluded to Salesforce and others. They do a good job behind the scenes in trying to normalize that data and actually create an MPI. But the problem is that in general across healthcare and then longitudinally across care settings outside the acute care centers, looking at long-term care, nursing, whatever else, there's no way to correlate. Remember, they didn't get dollars in 2009. They didn't get money from Obamacare. They didn't. They're still on paper most of the time. So to the degree of it, all these things cause inequities, which cause hesitation and leads to the fact that we're dealing now with a, I think, fourth wave here, because we have what, 40% of the country refusing to get vaccinated. Are we surprised by this? That's the problem we're running into.
Yeah, you know, both Aaron and I, you'll find us in DC. You know, I have, I don't know if I'm aging myself, but if anybody saw Schoolhouse Rock and remember seeing that, and I'm just a Bill. I had the absolute pleasure of representing the industry to testify in front of Congress, and I actually had something turn into law, right? And I say that, I tell you that from a perspective what Aaron mentioned, that seeing that whole process. But I can tell you, I was at the tip of this entire multi-year process in order to just get that bill passed. So, you know, it was a component of meaningful use and trying to change the narrative there. But what Aaron's referring to is things like national patient ID. You know, the fact that we have not been able to move and talk about the inequities associated of not having a patient ID, not being able to determine if a patient got their vaccination and they went from one site to the next, so that we can collectively, or went from one state to the other, to ensure that there's an identifier and having a collective system being able to summarize the care of that patient. That's a problem. And we've been fighting this for years now. And I'm hoping, not the best strategy, but I'm hoping that as many more of these things occur, we would be able to help. I mean, it is very clear and evident that there are, you know, health inequities, and we've seen that loud and clear. Just saw a recent report that you know, African American lifespan has decreased, and Latinx have decreased 3 years, and whites 1.5 years. I mean, these things are real, right? And there's disparities, you know, double. You know, it's a shame, you know, people, vaccines and getting vaccines distribution, or the death rate that we saw several months ago, it was disproportionate to these inequities. And also, I think there's another dynamic. And I think it's unfortunate, the education aspect, that when people went home and the kids were being schooled, there was a good portion of people that just did not have the technology or the internet access. So these things span much bigger than, you know, what we consider traditional health, but it does have repercussions. So I think it's imperative that we all be able to talk in plain English, you know, and also try to you know, take lead in taking it at the local level to make sure that you are doing the right thing for the community that we serve. Because after all, that community is our family. It's our cousins, it's our uncles, it's our wives, it's our husbands, it's our children, and it's our friends. So we have to keep in mind that we all have to do our part in order to fix this problem. We cannot hide it.
And you both previously spoke about some of the language challenges. I mean, tell us a little bit about, you know, the barrier with the patient speaking so many different languages and how you've addressed that so far, you know, at your institutions. I think the audience would find that really valuable, particularly as us being in Los Angeles, an incredibly diverse area. I know that for us at UCLA, we had some of our physicians were working on translational services to try to help, particularly also for family-centered care, because a lot of the patients who were lower socioeconomic statuses couldn't drive all the way to be with their family members because they had to work. And then how could you communicate when you don't have maybe a translator there in person? So I know both of you have done some work on that, and have found that to be, a challenge with addressing.
Let me start with that, and I can give you a small example. During the COVID, I volunteered to do the vaccine administration at one site. We had a family, about 7 people, come in at one time, and they were Nepali. And the Nepali, they were deaf Nepali, so they could not hear. And it was interesting because they had a translator because of the different dialects in Nepali. They had the translator deaf as well, had to have a translator that was American, that was able to translate in English. That person was also deaf, needed to be able, they could only read lips. So there were 3 to 5 different levels of translation to take care of this population just so that they get vaccinated. I mean, my mind was blown away by that concept, right? That, and then they use the video. We had a video monitor that, connects with people. And it was amazing, even to the point of, we had to take our mask down because that person needed to interpret, right? And, because of the lip reading component. So that's a component of how complex the care can be, Ryan. And it's amazing. And we have these technologies in play. One of the things that we're working on in one of our new hospitals and how we differentiate, we're putting in a augmented reality wayfinding technology. I actually have a version of it up on my screen here. And what we're going to do is, while patients are going in, they're going to be able to select their language and be able to navigate via AR in the event anytime they see a sign, that sign will be translated into their native language. So these are the kind of things that you're really talking about. We wanted to do it to help our customers and our patients, but these are the things that we're going to have to do in order to make things better. And we're also looking at it from those who have, vision impairments, being able to use AI to see if that person has something in their ear so they can hear, but the AI piece will be able to identify if there's a spill, identify there's something that they need to walk from. Again, using our technologies and doing wayfinding to have a different experience for all the people that we're serving.
Mm-hmm. That's really cool, Cletus, the AR thing. I'll pick your brain on that later on. So for us, very similar to that. There were a couple of components. One, especially when we went to a full telemedicine, when we suspended elective surgeries, it's amazing that the translation services out there just didn't keep up with the Joneses. None of them did. So if somebody comes up with a better translation service, you'll be a billionaire like a Zoomer in a heartbeat, right? So I have not found one commercial one. So it doesn't surprise me that Cletus is working on something custom, because right now they're terrible. They plug in, they're very unresponsive, they're very unfriendly, uncustomer service-like, and it's sad, right? So 2, the other thing we realized quickly was that a lot of our instructions were in English and Spanish, which accommodated for about 60% of our patients, but we had a 40% of other, right? That had either they were colorblind, they needed Braille, they were in other languages. So we really quickly went sort of the cheaper version of what Cletus is doing with QR codes, where you could click a QR code and up would pop an electronic version, whatever dialect and whatever language you want, you could read. If not, you could also, it would read out to you. We had these iPads configured that would actually read back to you the menu. It was just a voice overview, automated overview, what the menu was or what the instructions were. Last but not least, exactly what Cletus was saying, having a bank of people that folks could talk to in various languages of the common, German, Korean, whatever, was important because people wanted that human touch. What we also realized was these complexities of who gets the shot first, second, third, and fourth create a lot of distrust. It was the right thing to do to segment people, but folks didn't understand that. Remember, the average person out there has a reading comprehension level of an 8-year-old. And so it's hard to explain to somebody that you're not important enough yet, right? The caregivers are more important to get a shot. And it was about availability, not anything about you, but people took it personal, which led to more inequity. So we've done everything we can do to level the playing field and really open the kimono per se, in terms of a language access and access, but systems were not designed for this kind of tiering and this kind of availability. So I'm glad to see Cletus looking at augmented reality. It's going to take that. It's going to take some next level touch to get people back engaged with their health systems and realize it's not an episodic thing, but a continual thing where you're invested in your own future going forward. That's the reality of it. So this comes down to a basic pyramid of trust, with trust being at the bottom layer, and having to establish and continue to establish that over and over again.
Yeah, and I know previous discussions talked about open notes and a changing culture of trust with the patients. So I think interesting trends and shifts and exciting work that both of you are doing. As we start to close out the session here, wanted to end us with thinking about what will stick post-COVID with the trends and things, some areas that you've seen really drive forward, like telemedicine and using these translational services and seeing these gaps and needs. What do you see, and also changing? What is the people have talked about the digital front door and reimagining the emergency room? What do each of you see as some of the innovations or policies that you plan to continue to advocate for, and that you think will stick, and that is highlighted as maybe a silver lining because COVID brought this to the forefront? What stands at the top of your minds?
Yeah, but I know we're running really close to time here, so let me just go quick. So there's three things. Number one, I believe a multimodal telemedicine, telehealth delivery is forever, right? Whether that's RPA plus telemedicine plus other technologies is no longer the four walls. So that's number one. We have to accept that. Number two, from a medicine perspective and delivery of medicine, it's not just that, but teaching the student of the future will always be a hybrid model. Before it was, you have to operate on a cadaver to go from MS1 to MS4 as a gross anatomy. Now, augmented reality and virtual reality is something that's totally acceptable, right? From a medicine perspective and training the workforce of the future. Third, I already alluded to it with the hyper agile and very mobile CIO and IT department of the future. But what I didn't talk about was anchoring by data analytics. I really believe that we have doubled down on the importance of understanding the value of hard empirical evidence, and discrete data will forever be more. The fax machines, the PDFs have got to die. And I think we realize that quickly in its whole circumstance.
Yeah, and I think that from my perspective, working from home is that's out the bottle, right? That cat's out the bag. It's not going back. We're not packaging that back up. So it's how do we then help facilitate? All of these are related, and then it goes into the digital access component. Now that all of these people know how to use, I mean, we just forced millions of people to use the technology. Not that it was right, it was needed, but that basically now set the expectations that won't go back into the bottle again, right? We are now out and we have to provide access to our customers whichever way they want. We've established, we had a 10, 20, 30 strategy. We now have a 0 strategy, again, real time, no matter where they are. Again, the key here then again is think about it this way. We now have clean data, right? Nowhere else have we ever had data that from our patients that because they wanted COVID, they wanted to make sure they got those shots. We now have the cleanest data possible because people wanted to give us that information, right? To connect with them. Now the question is, how do we tie that in and engage the customer wherever they are, and making sure that we are not reaching out, not being, overreaching, but really engaging those customers anywhere within the organization, within the ecosystem of care.
Excellent. Well, Cletus, Aaron, thank you for joining the ScaleHealth community. I think we covered a lot with policy to innovation, translational services, and equity. Really appreciate you joining. Any kind of closing thoughts as we end the session? I think this was great.
I would just say this: be safe. It's coming back. Get vaccinated. Encourage everybody to get vaccinated, and just be cautious. Technology will play a difference, but it's up to us having each other's backs to really get through this.
Yeah, ditto to Aaron's point about vaccination. Continue fight through the fake whatever. And the last thing I say is innovate. Continue to innovate. Challenge us. Challenge healthcare institutions. Know that we are now. It's out of the bag. Push whatever we can, but really understand our business so that we can help us be successful.
Amen. Well, thank you so much. I'm going to turn the microphone back over to Taylor, but wonderful discussion. Thank you for joining.
Bye, y'all.